Your bread and butter imaging is in CT scan, other than chest, is paranasal sinus, or sinonasal. And the most common pathologies that you are going to come across is sinusitis, polyps, polyposis, which includes AC polyp also. But you will be surprised that there are so many pathologies that we see, or you will see, and I do see in my setup. Also, the sinonasal cavity is one of the most histologically diverse. You have skin, you have cartilage, you have bone, you have nerves, you have lymphatics, you have arteries, vein, everything. So imagine everything can go into pathology. Tumor, yes, but otherwise also pathology. You can have a fibrous dysplasia of the nasal turbinates because there is bone there, correct? So you should know the anatomy and the pathology separately and unite them for paranasal sinus approach cases. Let's go on to the first case. 40 years old with a swelling over the frontal region. Now this case, if your mind, you will identify with your eyes, but if you don't know, this easy case can become difficult. What do you see here? Let me take the laser pointer. Okay. My mouse is down here, so I am bending. Okay, so also you are used to seeing paranasal sinus or sinonasal pathology on coronal. Do see it on axial and sagittal, and do see soft tissue, at least cursor. Okay. If your technician is doing the filming, see to it that the soft tissue window, if there is a pathology, is in your report. Now what you have here? You have opacification of the frontal sinus and you have a lesion here which is in the scalp, frontal scalp area. Bone window shows you a focus of erosion in the anterior wall of the frontal sinus with a big bump here. As I told you, look at this sagittal image. Again, opacification and the bump here. No contrast has been given, okay? And what else are you seeing? You're seeing thickening of the walls of the bony walls of the frontal sinus. Means it's chronic. It's not acute. Whatever disease is in the paranasal sinus. I have not even said whether it's infective, inflammatory or whatever. I have not given contrast. Trust me, it is not neoplasm. And there is a erosion. So what do you think this is? Excellent. So this is a pot puffy tumor, a misnomer because it's not a tumor, a non-neoplastic, and it's a subgaleal collection or a scalp collection. And subperiosteal abscess, you can get osteomyelitis. Frontal sinus is the most common, but it can further extend intracranially and cause empymas, epidural abscesses, meningitis. To an extent, it can go cerebral abscesses, venous sinus thrombosis. So, PPT, pot puffy tumor. So, I told you I am not going to show you sinusitis. Acute sinusitis, nobody investigates. This is a companion case. These are two different cases. There is opacification of the ethmoid as well as a sphenoid. And what do you see? You see an complication, correct? It's a sorry, I didn't hear. Okay, so this is a subperiosteal abscess which is an extraconal causing mass effect. And you have to go and see the bone window. So axial is important to show you the whole extent of the lesion across the medial rectus muscle, which is also in the preseptal and postseptal extraconal compartment. See, the medial rectus flushes with the lamina papyracea. Look at the medial rectus, it is displaced laterally. So this is a complication of sinusitis. So finished, pot puffy tumor and this. Let's go on to the second case. 42-year-old presented with swelling on the cheek now. A non-diabetic. Trust me, you must ask this diabetes or non-diabetes since 1 month. What do you have? Now this is what I called as multi-compartmental. Sinonasal is one compartment, but it is gone beyond sinonasal. So you have a soft tissue density lesion on axial and coronal. I have kept bone windows and sagittal. Which compartment? It is in the nasal cavity, it is in the maxillary sinus, it is in the premalar and on the cheek area. It is gone into the infratemporal area and in the orbit. See here, so there is erosions of all the walls of the maxillary sinus. So it is multi-compartmental lesion with erosions of the medial wall, floor of the maxillary sinus, so all the walls practically. So you should do what? What do you think this is? So we do an MRI. I know this is not an MRI conference. You need to do, because is this sinusitis? No. Is it fungal? Though even if I tell you this is diabetic patient, this is not fungal. Okay. This is a multi-compartmental. The lesion is so aggressive and only 1 month. So aggressive that is eating up all the bones and going everywhere. It is partially, if you are in a center where you have gone home and this CT scan was done and they have not done contrast, don't ask for contrast. Go ahead and do an MR. Because in my mind, I'm thinking this is a tumor. So you have all these T2, T1, T2 again, this is coronal stir, this is diffusion ADC, and these are your post-contrast. So rather do post-contrast in MRI. And what are you seeing? Apart from this multi-compartment, you saw this premalar, malar and intraorbital nasal, and it's going everywhere. But what is the pattern it looks like? It looks like a cerebriform pattern, correct? It looks like all gyration, gyri, correct? So in my mind came that maybe this is a inverted papilloma, correct? But inverted papilloma should not go everywhere else like this multi-compartmental. Then, am I dealing with inverted papilloma which is got transformed? It is showing malignant transformation. That's a better diagnosis. So basically you should know what is an inverted papilloma. Mind you, general radiologist will report an inverted papilloma when it is only in the nasal and maxillary sinus. I'll show you that companion case as polyp. Because many a times you don't do contrast CT. So inverted papilloma is a Schneiderian papilloma which is the most frequently encountered benign neoplasm. Did that lesion look benign? It didn't. But it did have cribriform pattern. Look at this, correct? This is the cribriform pattern. Here also. And MR tells you, see on CT, we don't know whether this is there any fluid component. Of course, with soft tissue, you know there is no fluid. But MR tells you that everything is soft tissue and there is no fluid. So IPAP is a tumor, which is a benign tumor with an endophytic growth. It occurs in between 7th and 5th decade. Men are more affected than women. Again, I told you cerebriform pattern or convoluted columnar type of pattern. The important point here is you have to look at the bony strut, which is, I couldn't show, this was because I think this is IPAP with squamous cell carcinoma. So the most important, I'll show you another case. Focal hyperostosis at the point of attachment. Why you have to show this, whether there is any conical structure, bony structure? Because that site has to be removed, otherwise it will recur. And everybody knows there are 3 types of Schneiderian papillomas. One is, commonest is inverted papilloma, others is oncocytic, and because this is endophytic, the other one is exophytic Schneiderian papilloma. Okay, so final diagnosis was inverted papilloma with malignant transformation. Trust me, we have seen even a polyposis, a polyp-like looking with inverted papilloma. So there are these hybrid lesions. So we did give this diagnosis because it was multi-compartment. Whereas, look at this. How is this? A well-behaved child, correct? Sitting in its own place. Now this is many a times called as antrochoanal polyp or antral polyp. It is not reaching the posterior choana much as yet. So soft tissue opacification in the maxillary sinus completely. But what is eroded? Whenever the medial wall is eroded, think of inverted papilloma. And contrast, there is hardly any contrast. This is what I was talking about, the bony strut. So this is where the bony strut is seen. I hope inverted papilloma is clear. Again, you don't see it only on coronal, or you also look at the sagittal image, because that is where you are going to see the strut very well. Okay, it's fine. We go ahead. Oh, So the same case for your benefit. So there is some kind of erosion, or this is the area of your nasolacrimal duct. So see, it is well behaved nasal. You can't really appreciate the turbinate anatomy. And this is the conical bone, the strut that I was being talking about. And see, it is not gone inside, it is not gone anywhere in the orbit or outside. And you know, believe me, only thing that is bothering me is this. You know what that is? Greater palatine canal. Okay, so that was. Now another patient. What is this lady? This lady has watery discharge from her nasal cavity since 2 months. CT scan done. Purposely I have kept a soft tissue window. So what you have? You have multiple defects. Oh, where did this come from? Multiple defects. So sphenoid sinus, and remember normal variants, pneumatization of the lateral recess, correct? So this bone, the pneumatized wall of the pneumatized lateral recess wall is very thin. Very high chances of that getting in trauma, it can get, there will be a fracture. But this patient never had any trauma. So there is defect in the wall, superior wall of the sphenoid sinus, and there is opacification. Now on soft tissue window, you will realize the density is 37. Here also complete opacification, there are air bubbles in it. Again, there is some kind of a break here. As you can see, as you go anteriorly to the pneumatized sphenoid sinus, you will see another defect, and actually you will see something protruding from the intracranial region into the sphenoid sinus, the defect, and this has the same attenuation as that of the brain parenchyma, and some of them is fluid, CSF. Now what? So you have to go ahead. I have not done MRI of this patient because this was just recently done. It will be done tomorrow or day after. Why? Because MRI is going to tell you whether this is just CSF or there is brain parenchyma. I bet on this being brain parenchyma, and this is probably the CSF. So this patient has a bilateral sphenoid encephalocele. Now whether this is an encephalocele or just a CSF, you never know. Now a companion case to this is this lady who has, right, again watery discharge, insidious onset, clear, there is vague history, but there is watery intermittent. What next? PNS CT scan. So you see a defect in the cribriform plate and something protruding. Now if the clinician says do a CSF rhinorrhea study, answer is, does the patient have active leak now? I will do it. Otherwise, I will not do it. Be bold in answering this. Why subject the patient to an invasive test of a CSF rhinorrhea study, CTCS? You have to put a LP, put the contrast. So we told the ENT surgeon, send the patient when she is actively leaking. Or I could do this CT scan and I will do a MRI which is heavily T2 weighted. Correct? A T2 weighted MRI. But what we decided, we'll wait. So there is this, and also I'm showing you sagittal image because I want you all to get this in your mind. You have to see sagittal images of paranasal sinus and also temporal. So we did when patient was actively leaking, and you could see this is the same patient, same area is getting opacified by the contrast that we injected via lumbar puncture into this, and it is getting into the ethmoid and the nasal cavity. Don't forget to put nasal swabs in the anterior necks because you want them to opacify, correct? Sometimes you may not be able to see the leak very well. You're seeing a defect but not exactly the leak. But if that side, like for example, if I was not able to see this of course is very obvious, but that right side nasal swab gets opacified with the contrast and it lights up, then you know that that is leaking. What we also do in our institute is add 1 ml of Gado and we do T1 weighted images because now the gadolinium is getting opacified and we can see the gadolinium come out. Okay, so we are doing this in our institute. So T1's waited, and this is a defect. This is not a trauma related defect. So this was a cribriform defect with a CSF rhinorrhea study.